Welcome, everybody. So what I was going to do this morning is, relay just my thoughts on, I was thinking about what's one word to describe what we just heard this morning, and all I can say is the word impressive, because this is probably, I've done dozens of talks this year. I think we're at my 40th or 45th, some crazy number like that, speaking at a bunch of different events and talking to a lot of health information exchanges, discussions about interoperability, and how much complaint there is in other parts of the country. But when you think about very big states like Texas or California, they have money, they're pushing hard, and they can't seem to get all of the things that they want to get done together. And just watching what Jan just presented here was quite impressive. It's pretty real, and when she says, that Delaware is a nationwide leader, that's not hyperbole. It's not something that she's saying just because she's a CEO and leading this environment. It's actually real, and there are a lot of things that people can come here and learn from. So what I wanted to do today was really establish, what are we going to do from a strategic planning point of view. What we'd like to say is that you want to do what the customer wants, and I think Jan mentioned that. But that's really hard, right? Because you have so many different constituents and so many different customers. So how do you pull that off? So we've got some great panelists here that are going to help establish that, right? So you guys are going to help Jan kind of figure out, what should the next 5 years look like? And of course, the rest of you are going to jump in and help with that as well. And the way I want to kind of frame this is to say, are we really looking at innovation from the outside and consuming what's being provided? Or are we going to try to figure out what are the innovations that we need so that we can tell the market about it, and then they create what we need, right? That's our big question over the next few years. Because for over the last 5 or 10 years, we just look, for example, to Silicon Valley or to New York and say, okay, somebody's doing Uberization here. Let's go do Uberization of medicine. Like, the heck does that mean, right? It doesn't mean anything. So then somebody comes up and says, well, we need mobile apps, and that's going to make our innovation strategy work. To the point where there's the silliness around mHealth and other kind of events like that, just focused around mobile. And that's, I say silly because think back in, let's say you were creating an event back in the year 2000 or 2001, and you said, okay, what should I talk about? And imagine if there was a conference called L-Health at that time, for laptop health. Well, how useful would that be? It wouldn't be useful at all because it's not the device that's driving the innovation, it's something else. And that's what we're going to really talk about is, what is that something else? What should drive the innovation? What does it mean to listen to our consumer? What does it mean to listen to the customer? Because the changes that Jan talked about that are coming over the next few years are really not they're not going to be driven by government. They're not going to be driven by institutions. They're going to be driven just like they are in other industries, which is people using our services. And it's actually very unique, and I was saying peculiar at first, in a good way, and very unique that DHIN is looking at the consumer as a core participant of the network. Lo and behold, that is considered unique. I mean, just imagine that word. It's unique to have the actual patients who benefit from all of this as a member of the network. And I say that that's special because it's not common. So the services that Jan is looking to help you guys with over the next few years to provide can get even more important when you give that input and say, what value does a community health record have? As we bring in the consumers, what do they need? What do they want from that support? And one thing to think about as you look at the value of what's going to be provided over the next few years is, what way can a provider transform what they are doing because they now have ubiquitous access to data? That's our central question over the next few years. The question is no longer, do we have access? How are we going to collect it? Where are we going to store it, et cetera? And like Jan said, you guys have solved that particular problem. It's successful, it's sustainable, which was music to my ears. I was just going to clap right there and say, you don't need to say any more, right? Just say the word sustainable and you're done, because that's how innovation continues. So let's think about that. And what I'd like for you guys to do is, it is a panel with us up here, but only because we're leading this conversation. We'd love for you guys to jump up and say, hey, why aren't you doing this? Or why isn't anyone participating in these kind of innovations. And so there are a lot of questions that you guys probably have, and I think you're going to get sick of me because I'm with you for a couple of hours this morning. So hopefully after we have this conversation, I'll talk to you a little bit about what a way to frame innovation looks like. But with that, let me go ahead and, you were already introduced to Jan, so let me let Ann introduce. And we picked everybody so that their names rhyme. So Jan, Ann, and Dan, and it rolls right off the tongue. And it's going to be very easy to continue that. That's right. Yeah. Go ahead, Ann.
Well, good morning, everyone. My name is Ann Lara, and I'm currently the Senior Vice President and Chief Innovation Officer at Union Hospital in Elkton, Maryland. I'm a nurse by background, and I have the great fortune to kind of bring together my clinical skills and clinical experience with informatics, and been doing this for a little bit of time. I'm really excited to be here because I'm a big proponent of sharing information in a secure way so that whoever needs the information about the patients will have it so they can make good clinical decisions about the patient care. Again, I've had the great fortune to work with DHIN as an HIE perspective. And when I first came to Union Hospital back 4 years ago, I think I was knocking on people's doors and why aren't we involved with DHIN? We're a border hospital, meaning that, and again, patients aren't static. They move from one place to the other. So we have a number of our patients from Cecil County going across the border into Delaware to see providers being treated at various and sundry hospitals. So it made good sense to share information. So I'm really excited to be here.
Great.
And I'm Dan Elliott. I'm currently the Medical Director of Christiana Care Quality Partners and the Christiana Care Quality Partners Accountable Care Organization. So presuming not a depth of familiarity with those terms, so I think it's important to understand Christiana Care Quality Partners is a network of about 2,600 providers, largely in the Newcastle County area. And we've organized that network to help take care of the 20,000 employees and dependents of Christiana Care. So it's a provider organization sponsored by the health system, trying to engage our providers to set up a leadership and a governance structure where the end user provider is very active and has a say in what's happening. And that's been a growing process. It's been in effect for about 2 years now. And then as of January 1st this past year, we started the Christiana Care Quality Partners Accountable Care Organization, which is a Medicare shared savings program. So it's an interesting arrangement where a group of providers contract with Medicare for the beneficiaries that our providers care for. We have what's called an upside-only arrangement, meaning that we have some financial benefit, potentially if we're able to both improve the quality or meet quality goals and decrease the total cost of care for patients. And what's been really exciting about our ACO is that it's a partnership between Christiana Care, Bay Health, and Nanacoke. And we're pleased to announce that in January, we'll actually be adding BB and Atlantic General Hospital in Berlin, Maryland. So we've had a large growth. We cover a big geographic area. We have some already very dynamic partnerships with the DHIN through the event notification service that drives the care coordination piece that is really important to our efforts. We're also obviously happy to have the connection with CRISP, both for Union and also now for Atlantic General. So I'm really pleased to be here and to share the provider perspective and what it looks like from a network side. I am a primary care provider as well, and I think it's also important to note that I'm a lifelong Delawarean. So I believe heavily in what we're doing, and I'm pleased to see whenever I hear that Delaware is a national leader, I think that's something we should all stand behind. So thanks for the opportunity to be here.
No, it's terrific to have you guys all here. So the way I wanted to kind of set up this conversation was looking at, especially with you guys as successful as you are individually, as successful as Jan has made DHIN itself. These are single institutions, and of course, without the community, that wouldn't happen. And so as institutions, I think reasonably you can say that there are leaders and laggards, but institutionally we're going to be able to do okay. We're going to have, when we're looking inside, we know what our challenges are. When we look inside, we know what our issues are. We can make out our RFPs, get our proposals, and get the innovations, get things done. But when you really look at the problems of today, the low-hanging fruit of what you could do by yourself is gone. That means that the only way to get success over the next few years is collaboration. Collaboration in a multi-stakeholder, multi-institution model is the only way forward. So now, the challenge there is most of us, whether it's on information technology side or on caregiver side or anything else, we've not been trained in a multi-stakeholder, multi-institution world. We've been trained for our institutions and our work. So I tend to think we probably have, at a minimum, a workforce innovation problem, which is, how do I get my workforces to understand the multi-institution, multi-stakeholder world? And you started the conversation, and in the last couple of slides, you were talking about you need to hire X, you need to hire Y, you need to hire Z. And it was great that you got Stacy here, because one of the ways of getting this communication, getting these problems solved, is you got to communicate all this. So I think it was a great first hire on Stacy's side. So tell us a little bit about what are your challenges that you're seeing with preparing your own people in this multi-institution, multi-stakeholder challenge, and in the multi-stakeholder world. And then I'll have you guys comment on what are you seeing individually, whether it's from the ACO side or from the hospital side, and is a workforce as big a challenge as I'm saying, or they can move if you can train them properly going forward. So Jan, tell us, how are you solving your workforce challenges first?
Well, I think I mentioned in my talk, it's going to be through a combination of new hires, contracting, and staff development. There's some areas where we realize, look, we've got good people, we've got smart people, and we've got very committed people. I am so proud of the DHIN staff, I can't begin to tell you. But the world changes, and you constantly have to learn and grow. And I'm a great believer in lifetime learning, and every member of my staff will tell you that I stress that rigorously. And so we have a yearly plan for staff development that says, what are the things that you're personally interested in, and what are the things that DHIN needs organizationally, and let's find the best match and make sure that we are investing in developing our people and developing the skills that they are going to need to be successful, and that we as an organization will need to successfully provide the services and partnership with our stakeholders. There are some things where we need surges, and so you don't want to bring on full-time staff with all of the tail that goes with that for something that's really just a temporary surge. And so we'll support that with contract staff. And some of it is we bring in contract staff with expertise that we know we need and don't yet have to help us learn what we don't know, so that we're then able to more intelligently go out for full-time hires. And then some of it is we just need new people with new skills that we don't have, and the time it would take us to grow it organically from within is time that we don't have. Mm-hmm. And we need to just find those skills and bring them on board. So that's the combination. Now, it sounds easy when you say it, but part of the challenge, of course, is identifying exactly what are those skills. Yeah. And exactly what are those needs. And so some of that we're doing through our Gartner consultation, for example, but we're also looking for feedback from our stakeholders to say, where are we falling short? Where are we doing well? Where do you perceive that we've got gaps? And we're going to take that seriously and do our best to fill it. Yeah,
that's terrific. And remember, so if you have questions, raise your hand and the mic will come to you. I'm going to start off with just a couple of questions for our honored guests here, and then we want to bring you guys in immediately, because it's supposed to be a large panel, not a 4-person panel up here. So please do. So, one of the challenges that Jan just mentioned is knowing what to do, right? And I think that is the challenge of our time. So 5 years ago, 10 years ago, you're in a fee-for-service environment. You want as many patients to come in, you do the services, you move on. But especially with you guys looking at value-based care and whatever that might mean. I mean, nobody actually knows what that means. So anybody who does know what that means, please see us and explain what that is. But let's assume that it means different things to different people at different levels. So what do you see in this multi-institution, multi-stakeholder world where you could say, I wish either Jan or DHIN would do these kinds of things so I can use data to help transform my practices? So what are your internal workforce challenges to move into the next few years? And then what would you want DHIN to do to help you achieve those goals that you're trying to set for yourselves?
That's a wonderful question. And again, when I kind of reflect back of, where we are and where we aren't from an informatics perspective, we've come a long way, but we still have a long way to go. Mm-hmm. So one of the things I reflect upon is that I truly believe that the tools and the information that DHIN brings to the table are marvelous, and they're there. And they're there for the taking, right? And it's my job as a CIO to figure out how to market, how to inform, how to show the value of those tools to my stakeholders. So for example, the world in which I live, again, Union Hospital, Maryland Hospital, unlike Delaware's reimbursement service, we have something called a global payment system, which means that we're in a Medicare waiver state, which means that the state of Maryland has said to CMS, we can do a better job managing your Medicare dollars than you can, and we're going to show you how. So the plan that they put in place, and Union Hospital was part of a pilot program like 4 years ago, total patient revenue, and now the whole entire hospitals in the state of Maryland have on global budget revenue, which means that we get a set fee, a bucket of money, if you will, to care for our patients. And that money, we don't get more money if we get more people. We don't get less money if we get less people. We're kind of constantly changing our rates to meet that bucket of money. We get incentivized to do well with making sure that we don't have any hospital-acquired infections, our quality metrics are up, et cetera. But we get penalized if our readmission rates go above the threshold that they are. And we were severely penalized last year because we didn't meet the threshold. So we're constantly looking at ways from a population health perspective, from how do we manage patients so that we can stop them from coming into the hospital. And one of the big things that we're doing, and again, this is the power of HIEs and the power of communication, is through an event notification that Dan talked about in terms of we get information from all of the Maryland hospitals, the Delaware hospitals, to our case managers that say, hey, Mrs. Jones just showed up in the Christiana Care ED. Maybe you need to make a phone call to see why the patient's there. So that's an important. So we know kind of where our patients are in the world in which we live. We also are using the data for population health. And we're getting down to the claims level too in terms of, and to the primary care doc level too in terms of which primary care docs have the most readmissions, which primary care docs and which patients from a diagnosis perspective have the most readmissions, and where are they centered. So that having that kind of that foundation then gives us the opportunity to make a deeper dive into what's going on with that patient and how we can tailor our care to the patient. The challenge, of course, is we love this stuff, right? So, but how do you get that information and how do you show the value of that to one doc in a box, right? Just kind of doing his or her thing on a daily basis. And the way that we've tried to do it, it's costly for them to get data. So how can we be creative in terms of, again, working with DHIN to get them the data that they use? The model that we had followed in the past, and it made sense at the time, is that when EMRs first came out, the providers were saying, I need access to the EMRs remotely. So what the model that Union had, and this was like 7 years ago, is they made that technology available in the physician's offices. And at that time, it was kind of the technology was such that we could do that. The information security requirements were that we could do that. That doesn't work anymore, right? So rather than, and it is costly. From a hospital perspective, I'm paying for lots and lots of interfaces. I'm paying for lots of, VPN lines, firewalls, et cetera. That doesn't make sense anymore. So we're pulling that back, and again, I'm incentivizing, if you will, by saying that, you're not going to have to share in the cost of that interface, doctor, if you work with DHIN and you get information from our system through DHIN, as opposed to having direct interfaces from my system to your office. And if you think about it from their workflow perspective, they get information still about patients through faxes, through printers, through snail mail, interfaces from our Meditech system, interfaces from LabCorp, from Quest. So what kind of workflow does that do for them? There's tons of paper that they're scanning into the system, and then they're trying to figure out, okay, I got 5 copies of the CBC on this patient. So the marketing that I'm doing is that if when you interface with DHIN, not if, but when you interface with DHIN to get that information, you'll have one source. And it's going to make your workflow a lot easier. Think about the time and that you'll save from a staffing perspective. So I think that's my challenge, and my goal for the next 2 years is I really want to get rid of fax machines too. Just because, there's so many different ways to share information. We're still dealing with technology that started back in like 80s maybe. It was a great thing back there, but we've come a long way, right? So let's make better use of the value of HIEs, the value of CCD exchange, and that's, but again, it's incumbent upon me and my staff to make that happen. And again, as Jan said, this is not easy work, but it's fun work, and it's hard, but you eventually see the value. And the primary care docs and the providers that I work with are getting it. Folks that like 4 years ago was like, oh yeah, I don't. They're oh yeah, let's talk to DHIN. And again, Jamie's been really, really helpful in terms of trying to get. And we've eliminated, Jamie, I think at least 10 of my interfaces by working with DHIN. So it does work, and there's magic to it.
And Ann, I'm going to just follow up on something you said. When you think about it, faxes are not that old a technology. And I think it's a cautionary tale to all of us that we can get so enamored with a particular technology or a particular solution that we neglect to recognize the better thing that is coming along. And so I think we all have to be aware of that we're pushing certain solutions today because they make sense for today, but 5 years from now, there may be a whole new set of things that we'll be saying, kill DHIN. I hope not.
No, I hope not.
Please
Right.
don't kill DHIN. But we do need to be aware that today's miracle cure is the thing that in a few years there may be something that's so much better that we'll all be saying, boy, if you missed the boat on that, you're hopelessly left behind. So we don't want to miss the boat.
Yeah,
Nope.
so there's a question up there. If I can just have Dan just say a few words, and then we'll take your question in a second. Is that all right? Or do you have
Yeah, no.
some burning question? You can go ahead if it's a burning question.
Well,
Go
since
ahead.
we are so-
It's a burning question.
He looks like he's on fire.
All right, go for it.
I think one of the important things and value that DHIN can play in the future is having data available so that we really can make evidence-driven decisions. So as part of that, you made a comment, and this isn't a technology thing, it's a data question. Zach Cooper at Yale did a study, published a study earlier this year on the high cost of healthcare. And one of the things he said was that a lot of our data comparisons now on population health are driven off the Medicare data, which only represents 16% of the population, and that isn't representative of the rest of the population. Are you doing any comparisons on your pricing under the global scheme versus, the pricing under the rest of the population?
That's a terrific question. Again, the state of Maryland is fully aware of that difference. However, and we do track Medicare versus all payers, and we take a look at that. But from a waiver perspective, since it's all about CMS, our focus is primarily on Medicare at this point in time.
Yeah,
Okay.
from a demand side, it seems like the insurers aren't asking for the same kinds, commercial insurance aren't asking for the same kinds of output as CMS is. So right now, it's not so bad. But that's actually a great question, Dan, from your side, is that running an ACO, that's got to be natural to your problem domain as well, is how do you get your, so Ann mentioned that some of her challenges are associated with communicating value, not just for DHIN per se, but anything new coming down the pike. So how are you guys communicating that value? Because I remember, so if you look back at nursing school, I'm sure there was a few classes on population health, right? No, of course not. So they don't call
it was called
public health
at that
back
time,
then, right?
And
So
it's kind of transformed itself now into population health.
that's right. So if you think about the way that we were trained, but today pop health is not actually what you were trained as in public health, right? Because public health was all about health. This is about health care, making sure that it's affordable, et cetera. So what are you guys doing on the ACO side? To answer, I think his question is a very good one, which is, do you share data out with anyone with respect to the value that you're preparing?
Yeah, no, I think that's what underlies all the work that we do, right? So everyone's in various stages of development of learning how to do that. In our particular environment, we have data coming through our commercial population, a slightly different provider network, but similar types of information. Then we have our Medicare ACO, which comes with claims data looking across, again, a Medicare population. And the issue is everything is pushing towards transparency. Everything is pushing towards ownership, availability of information, and how do you address the value equation, the value proposition. So we use that all the time. That's the way we're thinking. It frames every decision. It frames everything we're doing. We're not there yet in terms of being able to integrate all of those things and come up with a clear picture of where we are. And I think that's what you were pointing out. We are learning, and we use the experience of our neighbors in Maryland to provide a little motivation. Both on the hospital side, but also on the provider side, to show what is coming. Because if we pretend that, the way we're doing business right now will exist for the long term, we're fooling everybody, including ourselves. And one of the arguments that we have that really propels us into the pop health space is recognizing that, things are going to change. When it is, how it happens, how sort of dramatic it is is hard to tell. Obviously, there's a political environment which has real implications for that. But the key is you don't want to be going 100 miles an hour when you hit that brick wall, right? So how do you use sort of what you know of the market to move in that direction? We use that, again, at every level. And so one of the things I really want to introduce, and I think Ann hit it, from a workforce perspective, the perspective of the primary care provider on the front line. And, you know, the provider right now feels like oppressed and beaten, right? And I'll tell you, you know, working with service lines, working with, you know, other specialists, working with, you know, all various peoples in the industry, everyone's first implementation step and last implementation step is, oh, if we can just get the primary care doctors to ... right? And to understand what that means is it has to be internalized by everyone. It has to be internalized by the DHIN and all of its strategic plans. It has to be understood by anyone in industry who's trying to use data, right? Because it comes down to how do you get that data into an environment where decisions are actually made. And I'm a huge proponent of understanding that every decision, Dave Fish and I were talking about with, you know, the nephrology practice, you know, where things happen is at the provider-patient interaction. All that we're doing at the network level or the health system level or, you know, even the Medicare CMS level is trying to create an environment that optimizes what's happening on a minute-by-minute, day-by-day, decision-by-decision basis.